All right. Good afternoon, I should say, I think. Good afternoon, everyone. This is the lecture for Lab 6. Before I transition to the lecture, however, I would like to say happy OT month to everyone. April is OT month, and I think it's important that we recognize the positive contributions that we make and the people that we work with across multiple settings. So, yeah, happy OT month. All right, for this lab, we are particularly going to take a look at different kind of strategies and tips for assisting people with mobilization. And we're going to transition also into talking about assist levels that we've had a chance to discuss a few times during the semester. And we're going to apply these assist levels into different kind of um, uh, occupational domains that we find ourselves assessing and working on as occupational therapists. So yeah, so the first thing that we're going to take a look at is bed mobility. Now, bed mobility essentially will encompass, adjusting in bed, right? So whether it be moving up to the head of the bed, rolling to the left, rolling to the right, transitioning from supine to sit to supine, right? So the first thing that we're going to look at is moving a person up to the head of the bed, and you will find yourself doing this quite a lot if you are working in inpatient rehabilitation, subacute, acute care, because people tend to slide down, especially people who may have a lot of movement deficits and are unable to adjust themselves. They are going to need help. So what are some of the tips to consider in doing that? The first thing that you want to make sure is that you want to make sure the bed itself is elevated to allow for proper body mechanics when you assist a person. The second thing that's important to consider is that depending on, of course, the person's mobility issues or deficits, that you will likely need a second person to be able to do this effectively and without risk of injury to yourself. Um, Now, you want to make sure that the head of the bed is flat and that the pillow is removed from the back of the head of the person. However, you want to make sure that the person's head is slightly elevated so that when you're moving them up, that their head is not being dragged across the bed. If possible, raise the leg of the bed, or adjust the hospital in what's called the Trendelenburg position if the hospital bed has that feature, where you actually tilt the bed downward, or I guess this direction, right? The head of the bed is down. Once you're in that position, you and the other person will grab the draw sheet or the slide sheet and slightly move the person upward. Once you are done, make sure that you readjust the bed to the position that is comfortable for that individual. And so that would potentially mean raising the head of the bed up, especially for people who are at risk of aspiration. So you certainly want to do that. And in many cases, hospitals do have regulations as far as how many degrees that the head of the bed should be elevated in the case of aspiration risk. Sometimes it can be 30 degrees, sometimes it can be 45 degrees. Once you raise the head of the bed up, you also want to make sure that you slightly raise the leg portion of the bed so that the person doesn't slide down again, right? In having a person move up to the head of the bed, you can also have them assist you if they're able to by bending their knees, or one knee if they can only do that, and push with their legs to move up. Okay, one good way to try to incorporate a person into this task.
So I'm Nancy Hireman.
We will not watch the video, but feel free to watch the video at your leisure, or watch the video, I should say, when you review the PowerPoint slides. All right, now moving the person left to right. I also want to emphasize here that when you assist a person mobilizing by rolling to the left or right, you're going to try to have them do as much themselves as possible, because we're not there to do it for them. We're there to help them be able to do things better. So again, raise the head of the bed for proper body mechanics. You make sure that the leg portion of the bed and the head portion of the bed is flat. You should have them use the bed rail as much as they're able to. Ask the patient to bend the knee opposite the direction that you're transferring them. So if you're rolling them to the left, make sure the right knee is bent so that they can push with that foot and roll themselves. Your hand placement should be at the hip and the shoulder of that individual. Um, that is on the opposite of the direction that you're rolling that person. Never ever pull on the person's arm. I see that a lot with, some of our maybe, mainly I see that a lot with family caregivers because they're not trained. Um, all right. The other thing you want to make sure is that when you have the person roll to the side, that the person is not already scooted to the edge of the bed, because then if you enroll them, you likely will run a risk of rolling them off the bed. And so you want to make sure that there is space between them and the edge of the bed when you're rolling them towards that direction, right? Now, if you roll them on the opposite direction, make sure you get yourself on the other side, right? And so that you're not in a position where you're pushing them away from you. Okay. You definitely could use slide sheets for bed mobility. Many currently use slide sheets. If not all of them have these handles that on the edges, and you can use those handles to roll a person over. You can use those handles to slide a person up, of course. All right, supine to sit, right? This is where the person transitions from lying down in the bed to sitting at the edge of the bed. The first thing that you're going to do is have them roll over to the left side. This is going to be important for people who have sternal precautions, of course, people who have hip precautions, back precautions, support for everyone. It's just an easier way to get up. In many cases, not intuitive for people. They use this sit and swing their leg over kind of technique. But the rolling is the best technique to assist the person in getting in and out of bed. Once they're rolled over, of course, you can have them use the bed rail as much as they can. Then the first thing that you're going to do is have the person move their leg off the bed. Let me see the slide real quick here. Yeah, I don't think the slide actually mentions this different sequences, but we'll go through them verbally, right? So you're going to have the person roll to their sides with their knee bent, of course, then have their both left and right knee move towards the edge of the bed or out of the edge of the bed. Then you're going to assist the trunk into a sitting up position. When you assist the person trunk into a sitting up position, your arm is going to be placed under the shoulder blade or the shoulder of that is making contact with the bed, and then on your other hand is going to be on the hip of that is opposite to the hip that is making contact to the bed, and then you're going to assist them in that transition into sitting at the edge of the bed, and we'll practice that in class. So there are different type of transfer techniques, right, or transfer methods. This is for when you then, you have the person sitting at the edge of the bed. Now you're ready to transition to a wheelchair, bedside chair, or a commode. The first is stand pivot. If the person is able to stand up with or without your assistance, of course, this would be the technique, right? This is where the person stands, turns, and sits on that sitting area. The squat pivot is where the person has 100% glute clearance, and they sustain that the entire time, but they're not fully upright. Their knees are not fully extended. So in that position, then they turn and they sit on to the surface area, and that's a squat pivot. Transfer board is what is depicted in this picture here. A transfer board is placed under the pelvis of the hip towards the chair. So part of the board sits on the bed and under the person's pelvis and or hip, and part of the board then also sits onto the surface area in which that the person is transferring. And the person is not sliding on this board. We talked about that in class, right? The person is scooting up towards the chair on this board. They can assist by pushing with their arms. The one thing that you do not want them to do is curl their finger under the transfer board. Never have them do that. What that can happen is that when the pressure is applied on the board, then their fingers can actually get hurt. So we don't want that to happen. A busy board is a different type of transfer board, and we'll look at that in a future slide. A busy board is a transfer board, but that has a disc that moves from one direction to another direction. It slides over. you will insert the slide board or the busy board the same way as you've inserted the transfer board. But you're going to make sure that the person is actually sitting on top of that disc. Then when you slide the person is not sliding on the board. The disc is sliding and taking the person with it. And then the person gets onto the surface area that they're planning to sit on. Great. Now, different considerations for when you're doing a transfer from a bed to a wheelchair. First thing is that you want to make sure the environment is safe, right? So that the wheelchair is close to the bed at about 30-degree angles from the bed. That the height of the bed is at the same level or slightly higher than the wheelchair if they're going from the bed to the wheelchair. If they're going from the wheelchair to the bed should be at the same level as the wheelchair or slightly lower if possible, right? You want to make sure the brakes are engaged and that leg rests are removed and positioned out of the way. Not next to the bed where the person can trip or you can trip, right? So move them out the way. Many wheelchairs have a swing away leg rest, right? Not fixed. Now, if you swing the wheelchair brakes away and not remove them and take them out, and remove them and place it someplace else, when you swing them, what they could potentially do is that one, they could swing back. Two, they could undo the brake that you just locked. And so the best thing to do is remove them and put them aside. Make sure that you and the client are on the same page or on the same page about the type of transfer is being attempted. I need some water. You don't want to be in the situation where you're attempting a stand pivot, but the person is trying to complete a squat pivot, right? And then there's a mismatch there, and that could create a confusion, and that could lead to difficulty with the transfer sequence. I'm gonna pause this real quick and grab my charger. All right, I think we're good here. You want to make sure that the person has proper footwear, either regular shoes or non-skid socks. No barefooted transfers, and no transfers with regular socks on. Okay, you also want to make sure that the light is on. There's proper lighting and all of that. If in doubt, always get second person to assist. All right, floor transfers. Now, there are, of course, two scenarios in which that you will have to do floor transfers. The first one is that you are practicing it with an individual, and this is planned. And so then you have the person lower to the ground purposely, and then they work on transitioning up into a sitting surface, right? The other scenario is that you encounter a fall, and let's say that you come into a hospital room and the person is on the floor because they attempted to get up, and unfortunately this happens from time to time. It happens, more frequently than we would like. Although many hospitals, of course, there are initiatives for prevention, and but you will encounter those from time to time. Now, when that happens, the first thing that you want to make sure is that you follow your facility's procedure to alert the proper medical team. You yourself, together with the medical team, will assess the person to make sure that there aren't any fall-related injuries that have been sustained, orthopedic, the brain injuries and things of that nature. And then also, in many cases, people fall because of a medical event, right? And the medical event may not have happened because of the fall. The fall may have happened because of the medical event. So regardless, a medical professional, physician, neurologist, whomever is in the clinic will have to evaluate that individual to make sure that they are okay to be transitioned into a bed or a wheelchair. If the person is physically capable of getting up, of course, you put the gait belt on and you'll have the person get up and transition into a bed or a wheelchair. That, of course, if there isn't any bed or wheelchair nearby, you're going to bring one for them. If a person is unable to do that, then of course, then you alongside your colleagues, nursing team, will have to assist the person into the wheelchair or the bed. In this case, what you'll have the person do is get into what's called the quadruped position by rolling into the weaker side. Quadruped position is where you have the person on their hand and knees. Then you will bring a wheelchair close to them or a chair close to them. Then they will go into a half kneeling position where their arms are positioned onto the chair, but their knees are down. From that standpoint, or from that position, then they will transition into a standing with assistance and then turn and sit on the wheelchair that they're sitting on. This is going to require practice, of course, to implement, right? Now, in the case where they can't do that, they require a lot of assistance for getting up. Then at which point, this is where you bring in a Hoyer lift or a mechanical lift to get the person up into a safe position. Always you have to think safety, right? So this is not, if you're encountering a person who's fallen to the ground, we're not necessarily using that as a training opportunity, right? We just want to get the person up into a safe position. So whatever is the safest way to do so is going to be what you will do. And if it is using a mechanical or Hoyer lift, that is what will be done. Now, you will follow the same routine if the fall occurred while you, of course, are working with a patient. And, as clinicians, of course, what we do is to prevent falls from taking place. But in the case that a fall occurs while you're working with a person, then you would have to utilize the same kind of strategies, right? Alert the medical team, evaluate the person. If everything is okay and the person is able to move, have the person get up. If not, use the strategy that we talked about. And if that doesn't work, mechanical lift, Hoyer lift is going to be appropriate. All right. These are the different adaptive equipments that I used for mobility. Gait belt, we know that. Transfer board, busy board is what I talked about. And that little circle that you see in the middle is a disc that you'll have the person sit on. And that disc moves left to right, and that's what you're going to have the person move on. A Hoyer lift, the one right next to the busy board is a Hoyer lift. Requires a sling. That gets placed under the person. The sling then gets connected into one of those hooks that you see. And then, of course, that lever in the back bottom of the machine, that's a crank lever that lifts the person up, and then you move the person into whatever that they need to sit on. There are electrical versions of it as well. The Sura Steady is a mechanical sit-to-stand machine. That's the one in the bottom left corner. The bottom plate that you see, that's where the person's foot goes. That pad right above it is a knee block, and the person pulls up on the horizontal bar that you see at the handle. And once they stand upright, those blue foam bracket things, they are movable, so you'll move them before the person stands. Once the person stands, you move those right behind the person, and the person can sit on them, and you move the person. The sit-to-stand lift is an electronic version of that that has a sling for lifting and maintaining a person in an upright position. All right. And these are things that, when you do your clinicals and also when you go into the real world to practice, practice occupational therapy, these are things that you will likely encounter, and your facility will likely do a training in how to utilize those. All right, so occupational analysis. So right now we're going to transition into the different assist levels that we've talked about a number of times during our semester. And in talking about the assist levels, I'd like for everyone to think about occupational analysis, right? So occupational analysis is something that we do on a day-to-day basis as occupational therapists. We break tasks down into smaller components, and not just from assessment standpoint, but also when we plan and implement our interventions. So when we determine assist levels, we're going to break down the different tasks into smaller subtasks, and we are going to evaluate a person's ability to do each of those subtasks. And based on that, we'll make a determination of the level of assistance they require, right? So before we transition into that, you've seen this before. These are the level of assistance. Review them. Make sure that they are second nature for you, because this is something that you will utilize in your practice daily. not just when you are evaluating a person or writing goals, but also when you're working with the person and documenting daily treatments. All right, so let's look at self-feeding. Some of these components or categories of function we'll look at a little bit more in depth, others we'll skim through. Now, from a self-feeding standpoint, if a person only needs setup, if the person needs somebody to bring their adaptive equipment, bring their meal, open their containers, that's, setup. If a person requires cues for attention, initiation, swallowing strategies, pace, and all of that, then that's supervision. If they require just intermittent assistance, from time to time, but they're able to mostly do their self-feeding by themselves, that's, I would consider that min-assist. If they are able to do 50% of the task, but they need help with the other 50%, of course, that would be like mod-assist. For instance, the person they need help for scooping, and then afterwards, unassisted, they can bring their hand to their mouth to take a bite. Then that would be mod-assist, right? If they need help most of the time, then max assist, that's that 51 to 75% rule. And then if they need, caregiver completes all of the self-feeding tasks for them, that's dependent. Same thing applies for, same strategy for the grooming task as the self-feeding. So we don't necessarily need to go into that specifically. Bathing, now with bathing, there's a 10% rules, right? So there are different components of the body that are broken down, and essentially we're looking at the right arm and the left arm, right? We're looking at the chest and the stomach area. We're looking at the posterior and the peri areas. So that's 6 total. And then you have the upper legs, that's 2, and then the lower legs, that's 2. So there are 10 different areas that we are looking at, right? So from a min-assist standpoint, if out of the 10 areas, if the person only needs assistance in 2 of the areas, that would be 25%, but in less than 25% assistance, that would be min-assist. If the person requires, up to like more than 2, but about 5 to 6 part of the body they need assistance in, that would be mod-assist. And if they do require more than 5, about 6, 7, 8 body parts needed to be assisted, then that essentially could be max assist, and anything more than that will be considered a dependent. Contact guard in this scenario would be like if a person is doing seated lower body bathing, and they're kind of leaning forward, and you're providing that hands-on support, meaning that you're not physically supporting them, but your hand is placed on them just for safety purposes. That would be contact guard. Same thing from a standing perspective as well. Now, upper body dressing has 4 different components. So when we break it down into smaller components, we have the left arm, the right arm, the pulling the shirt overhead and pulling the shirt down. So those are the 4 different components. Each of them are assigned 25%, right? So if a person is able to the person only needs inserting the sleeve over the left arm, but they can do, or one arm, but they can do the rest themselves, that would be min-assist. Right? If let's say they need assistance in threading their arms, but then they can bring it over their head and pull it down, that would be moderate assist. If they're able to thread their arm, over their shirt over the right arm or the left arm, let's say, but they need help with the rest of the components, that would be max assist. If they need total assistance, if they need assistance with all of those components, then that would be dependent. Now, I'm not going to go into lower body dressing specifically because it has the same kind of process, right? There's the left leg, right leg, donning pants over the hips, and then fastening the pants or making them tight. And so there's like a 25% component there, over 25% each, right? And so the same kind of rule for upper body dressing applies. From a footwear standpoint, that's so that includes socks and shoes, so that you just kind of you're documenting footwear versus separating them between socks and shoes. There are 6 components total, right? Put the left socks, put the left shoe, tie the shoelace. Same thing with the right side. Now, if the person wears slip-on shoes, which are pretty common right now, right? Who wears the lace shoes anymore, right? In that case, then the components are come down to 4, and that essentially then will follow the same rule as the upper body and lower body dressing, meaning the shirt and the pants, right? In this case, min assist would be if the person is able to complete 3/4 of the tasks. If the person is able to complete, half of the task without assistance, then that would be moderate assist. If the person completes one of the components but needs help with all of the other ones, that's max. And dependent essentially means that the person needs total assistance for all of them. Toileting is broken down into 3 different components. You have the pants down, hygiene, pants up, and so there's a 33% rule there. So min assist essentially is that the person is able to complete all 3, but they need a little bit of assistance from a thoroughness standpoint, maybe from the hygiene perspective. Mod assist essentially means that the person is able to complete 2 out of the 3 components. Max assist, the person is able to complete 1 out of the 3. Caregiver completes the other 2, and then dependent is that the caregiver completes all 3. From a prosthetic standpoint, it's also a 33% rule, same as the toileting rule here. Now, the prosthetic component or donning prosthetics involves the liner, right? Donning the liner, right? I'm sorry, I'm getting distracted here. Donning and then, sorry. So prosthetics has a liner, a socket, and a locking mechanism. That's pretty much what the traditional prosthetics for the arms and the legs have. Now, there's something that's called osseointegration. That's something kind of recent, and that is becoming more and more adapted into the world of prosthetics and amputation. And this is where the liner or the mechanism that locks into the prosthetic device is surgically implanted into the residual limb of the individual. So that metal piece is surgically connected to the person's bone, and all they have to do now is insert the prosthetic right on that. So they don't have to worry about putting the liner on and make sure the liner fits and stuck, and all of that. So that's kind of becoming more common. Now, in this scenario though, the traditional prosthetics, which we see more often, is what we're considering. So in this case, there is the donning, there is the adjusting piece, and there is the doffing piece, right? So there are 3 components, 33% each. So when we consider that, it essentially is the same as the toileting, right? And so we're not going to go into more specifics of that. So you can apply the same principle as the toileting to this because it is 3 components. Bed mobility has 3 components for each: supine to sit, sit to supine. And again, you are going to apply the 33% rule for this as well, for both the supine to sit and sit to supine, because you won't always assess both at the same time. And so, or you won't always look at both at the same time. So you're going to apply the same rule as the 33% that we've applied for prosthetics and toileting. Transfers. If a person requires you to retrieve the mobility device, the cane, the roll walker, whatever it is that they need, that's a setup assist, right? If you need to place your hands on them as they transition from one surface to another surface, not necessarily provide physical assistance for balance, but they may need benefit from that hands-on support, confidence perspective, facilitation of movement, that might be that is contact guard. If the person requires cues for safety, right? They don't need physical support, but they need cues for initiation, safety, the sequencing of the transfer, the technique, hand placement. That is supervision. If they do need support, that is about 25% or less for balance or for the pivoting sequence, that's min assist. If they require anywhere between 26 to 50%, that's mod assist, 51 to 75 max, more than 75 dependent. It would also be dependent if they require 26 to 50% assistance, 51 to 75% assistance, but 2 people. That's going to be considered dependent. Same concept applies with mobility. I'm not necessarily going to go into that because it's the same thing as the transfer. All right, so that's kind of it for this lecture. Apologies if I run through it real fast, but if you have any questions, bring it to lab next time because we're going to get hands-on with transfers and things like that. So bring it to next lab and we'll talk more about it. One thing that I will leave this lecture with is that it is very important that our evaluation and assessment of a person's level of assistance is accurate. You want to make sure that you follow these kind of standardized protocols and how to evaluate, because we don't want 2 clinicians seeing the same person and saying 2 different things about the level of assistance that the person requires, right? There needs to be consistency across the board. This is how we communicate the level of assistance that the person needs to the multidisciplinary team, to our social workers, to our nursing team who rely on that information to make decisions on how to mobilize the person. The nursing tech team, they rely on the information that we give to properly mobilize the individual, and family members as well. And so it's important that we are accurate in our assessment of a person's level of assistance that they require for the very different things that we talked about just now. All right, well, you all have a great weekend, and I'll see you all on the 6th. Bye. Lab 6. Bye.